Hello, everybody. My name is Dr. Howard Chaps. I'm the Medical Director for Healthcare Excel. And today we're going to be talking about venous thromboembolism measures, or VT measures, that have recently started to be mandatory reporting measures by our hospitals and our providers. And throughout the presentation, here's what we're going to talk about. We're going to mention the background of the measures, the subpopulations, or the patients that are included in the measures, as well as those measures that have certain exclusions with them, as well as documentation required by the physicians as well as the nurses or the caregivers while in the hospital. And we'll, as we go through this, we'll go through these in pretty good detail. So from an overview, from a background standpoint, this is, again, a new measure set that has become mandatory by the Joint Commission, as well as CMS, starting January 1st of this year. In the past, it's been a voluntary measure. However, again, starting this year, it's going to be something that's being required by the providers to submit their data quality reporting. It's been developed throughout the years via a joint effort between the Joint Commission as well as the National Quality Forum. The National Quality Forum is a nonprofit organization that is involved in promoting healthcare quality throughout the United States. And with these measures, there's extensive evidence, and we're going to go through some of the evidence as to how these measures came about and as to why these measures are being looked at by these agencies. Again, and these measures align with CMS, what CMS is trying to accomplish, and they're trying to accomplish the method. They're trying to improve the quality of care for their patients. So, as we stated, this is the data needs to be submitted starting again beginning of this year. And this information is going to be presented or is going to be seen on a website called Hospital Compare, which is a website that publishes quality information or quality data or core measures for all the hospitals throughout the United States. So patients and insurance plans, hospitals, hospital administrators will be able to see how their hospitals are doing versus hospitals in their region or hospitals in different states. And it's a public reporting website that just tells you how well your hospital is doing. Those hospitals that do not report this information are at risk for losing 2% of their payment from CMS. And as we all have seen in the past, what CMS tends to do, the private payers tend to follow. So not only the hospitals are encouraged to improve the quality of the care the patients receive, also they're at risk for losing some compensation should they not participate in submitting this data. The next thing we're going to talk about are the subpopulations, or the populations of patients that are included in the measure. And I'll go through this, but you'll understand what these subpopulations are a little bit better as we progress through the actual measures, and you'll see exactly what I'm talking about. So subpopulation 1 are those patients that do not have a principal or other diagnosis of VTE. So these patients don't have a PE, don't have a DVT, and this is defined as an ICD-9 code and can be found in a specification manual. And this is a manual that helps providers, physicians, data abstractors understand the exact measures and what needs to be reported. And if anybody wants to see the specification manual, the quality data department in your hospital will be able to show you exactly what I'm talking about. But again, these tables 702, 703, and 704 refer to ICD-9 codes. Specifically, 702 is the ICD-9 code for obstetrics. 703 is the ICD-9 codes for venous thromboembolism, and 7.04 are those codes that are obstetrical venous thromboembolisms. So again, for subpopulation 1, these patients do not have a DVT or PE. Patients need to be over the age of 18 and have a length of stay in the hospital of less than 120 days. This will be a recurrent theme throughout the presentation for these populations, those over 18 and then a length of stay less than 120 days. Subpopulation 2 are patients with a primary diagnosis of a DVT or pulmonary embolism. And these patients, again, are over 18 and have a length of stay in the hospital less than 120 days. And then finally, subpopulation 3 are those patients that do not have a principal diagnosis of a DVT or a PE, but they have a secondary diagnosis of this. And again, table 703 and 704 are the patients that are the ICD-9 codes that include these patients. And here are the measures that we're going to talk about. VTE1 is prophylaxis on a medical surgical floor. VTE2 is venous thromboembolism prophylaxis in the ICU. VTE3 are those patients that have a DVT or PE that are treated properly with overlap therapy, meaning they get a parenteral as well as an oral, or they get warfarin as their oral medicine that they use for treatment. VTE4 are those patients who are treated for a DVT or PE with unfractionated heparin, and these patients are monitored, have their platelet counts monitored, as well as their dosing of unfractionated heparin monitored as well. VTE5 is how well discharge instructions are given to the patients, and then VTE6 talks specifically about the DVT or PE that develop while in the hospital. We'll go through these all at length. And here's a picture that describes how the subpopulations are linked to the measures. And again, as we go through this presentation, you'll understand a little bit more as to what this picture means. It'll become much more clear. But subpopulation 1 are included in measures 1 and 2. Subpopulation 3 and subpopulation 2 and 3, are included in measures 3, 4, and 5. However, only subpopulation 3 is included in measure number 6. And again, as we go through this, it'll become much more clear. So let's jump into the measures. VTE1 is VTE prophylaxis. And specifically, this measure assesses the number of patients who receive VTE prophylaxis or have documentation why no VTE prophylaxis was given. And this information needs to be documented the day of or the day after hospital admission, or surgery end date for surgeries that start the day of or the day after hospital admission. And what's expected by CMS and the Joint Commission is that medical surgical patients should receive some sort of VTE prophylaxis. And the rationale is pretty clear from the data that's been looked at over the years. We know that hospitalized patients have a higher risk for developing a DVT and PE. They can occur suddenly. They cause death. And we know that throughout the United States, yearly, approximately 2 million people develop PEs or DVTs. And this is direct data that comes from AHRQ, or the Agency for Healthcare Quality and Research, which is another government agency that promotes quality healthcare for patients in the United States. A little bit more rationale. 2/3 of DVT PEs are related to a recent hospitalization. A study done in 2008 that was published in The Lancet looked at about 17,000 patients, and they found that about 38% of patients did not receive prophylaxis. And again, going back to what AHRQ states, AHRQ states that venous prophylaxis is the #1 patient safety practice for hospitalized patients. So from all the data that's been gathered over the years, all the agencies, CMS, the Joint Commission, National Quality Forum, AHRQ, everyone has come to the conclusion that preventing DVTs and PEs is a pretty important step to making our population healthy. A little bit more of the rationale. Chances of having a complication from prophylaxis is small. We know it's cost effective. The benefits clearly outweigh the risks. And from the data that we've looked at over the years, we know that fatal pulmonary emboli can be prevented. This was a paper that was published in Chest in 2008. So again, the data is pretty good for this. And as we've all seen, compression devices that could be used for venous prophylaxis, just a picture for you. So next thing we're going to talk about are the patients that are included or excluded in the measures. And we're going to talk a little bit about numerators and denominators really quickly. And this information will be information that you'll see over and over again. However, when you talk about a numerator, you're looking at those patients who receive what the measure intends. And the denominator for all these are those patients that qualify for the measure. And you'll see for the most part, you want these numbers to be as close to the same as possible. However, in the last measure, you want the percent to be at 0 or close to 0 as possible. And again, you'll see what I mean as we go through this. But again, numerators and denominators are going to be a recurrent theme. And this is used by the abstractors to get the data submitted to the Joint Commission and CMS. So in VTE1, the numerator are patients who receive VTE prophylaxis or have documentation as to why no VTE prophylaxis was given. And this has to occur on the day of or the day after hospital admission, or the day of or the day after surgery end date for surgeries that start the day of or the day after hospital admission. And there is not an excluded population for the numerator. And your denominator is all patients. However, some patients are excluded. Again, patients less than 18, length of stay less than 120 days, patients who have comfort measures only documented on the day of admission, patients enrolled in clinical trials, and then patients who are admitted to the ICU with a length of stay more than 1 day in the ICU are not included in this information or this measure. They're included in the next measure. Patients with mental disorders are not included. If patients have a principal diagnosis of a stroke, they're included in a different measure that's looked at by Joint Commission and CMS, and they're not going to be included in this population. Obstetrics is excluded, and then patients who are included in the Surgical Care Improvement Project, or SCIP measures, they're not included in this as well. You can't be in two measures at the same time. So here's some information for you about what is required by the physician. If the patient refuses to have VTE prophylaxis, or the family refuses to have VTE prophylaxis, it needs to be documented. It can be documented by a nurse, but again, it needs to be in the medical record. And when this is being documented, it needs to be documented in the same time frame as when the order would be written, so the day of admission or the day after admission. And then for this measure, or if a patient refuses one type of treatment, such as compression stockings, it counts for refusing both types. So any kind of pharmacologic method of VTE prophylaxis, as well as the mechanical type. So all the patient refuses one, it qualifies to be refusing both of them. Some more documentation information for you. When the physician decides not to give VTE prophylaxis, that's fine. However, there are certain requirements that are mandated by CMS and the Joint Commission. You can't just state the diagnosis, such as thrombocytopenia, IVC filter. It's got to be a little bit more in depth. So, for instance, the patient has an active GI bleed and Lovenox is contraindicated. Something to that extent where when they abstract the data, they know that these patients were not given VTE prophylaxis for a reason, and patients will fall out. And when this is being done and documented in the medical records, you have to document both types of prophylaxis, so mechanical as well as pharmacologic. When patients are documented to have comfort measures only, it has to be on the day of admission, day of surgery, the day after surgery, but it has to be documented in the same time frame. And then patients who are getting anticoagulation therapy for another condition, such as for acute MI, who are getting Plavix, or getting aspirin, that doesn't count. They need to have certain medications that are accepted by CMS and the Joint Commission as the medications that are used specifically for venoprophylaxis. And then when these medications are being listed that are proper, the route has to be listed as well. If the INR is high and patients are receiving Coumadin or warfarin, it's got to be documented as well as to why venous prophylaxis was not given. But again, it's got to be documented very, very clearly in the medical records, or else there's a risk for the patients falling out of the measure. If the patients have a contraindication to pharmacoprophylaxis, you still need to document why mechanical prophylaxis either was not given or mechanical prophylaxis needs to be given. Another frequent mistake that we sometimes see is that mechanical prophylaxis is started 2 more days after admission. Again, if there's a contraindication, it's got to be documented. You need to document on the day of admission or the day after admission, and then both measures need to be addressed, again, within a day or 2 time frame. Ambulation is not a reason for no venothrombo-prophylaxis. Need to document, again, why both measures are not being used, or both methods are not being used, excuse me. Here is a picture of Dick Schaap. He was a famous sports reporter. He died in 2001, after hip surgery, and there's some controversy of whether or not he died from a PE or not. There were some issues whether he had lung issues from amiodarone therapy. However, I want to show you some pictures throughout the stay of some patients that have had some really poor consequences from DVTs and then PEs as well. So with that, we're going to go into venous thromboembolism measure number 2, and this is prophylaxis in the ICU. And these measures are pretty similar to VTE1. The description exactly is the measure assesses the number of patients who receive VTE prophylaxis or have documentation why no VTE prophylaxis was given. And then, very similar, the day of or the day after admission to the ICU, or surgery end date for surgeries that start the day of or the day after ICU admission. So wording is pretty similar for the two measures that we've discussed thus far. What's expected, in general, is that ICU patients receive some form of prophylaxis, unless they don't have an overnight stay, or there's a reason given as to why they're not getting prophylaxis. And the rationale is that being in the ICU, in and of itself, is a risk factor for getting a DVT or a PE. Some of these risk factors are related to the illness. Sometimes patients are immobile, they have central lines, they're mechanically ventilated, and they're at higher risk for getting a DVT, PE, and prophylaxis has been, again, proven to be beneficial for these patients. And in the numerator, there are the patients who receive VTE prophylaxis or have documentation why no VTE prophylaxis was given. Again, the day of or the day after ICU admission, and then the day of or the day after surgery end date for surgeries that start the day of or the day after ICU admission. So this all comes from the specifications manual, which is readily available from your quality officers in the hospital. And we're not going to exclude any patients in this population. In the denominator are those patients who are in the ICU. However, for this, as we'll see in a few moments, the patients need to be in the ICU for more than a day. But again, the excluded patients are less than 18. Patients in the hospital more than 120 days. Comfort measures need to be documented. Patients in clinical trials. And as I alluded to a few minutes ago, patients with an ICU length of stay less than 1 day without VTE prophylaxis administered, and documentation for as well as if there's documentation for why no VTE prophylaxis was given. These patients that are excluded also are patients who have a DVT when they get there, and those patients who are involved in some of the surgical codes as well. Derek Thomas, linebacker for the Kansas City Chiefs, was involved in a car accident, became paralyzed, and then I think during his rehabilitation in the hospital, he developed a DVT and a PE, and he died. So these are real life people that are affected from these disorders. So VTE number 3 is called VTE patients with anticoagulation overlap therapy. And what this measure does is it assesses the number of patients diagnosed with confirmed VTE who receive an overlap of parenteral anticoagulation and warfarin therapy. And that's the exact description from the specifications manual. And it applies to those patients, and the magic number here is going to be 5. For patients, and overlap therapy needs to be administered for at least 5 days, and during this time, the INR needs to be equal or greater to 2 before anticoagulation parenteral therapy can stop. If patients go home before 5 days, they need to be discharged on both medications, and if they're not, there needs to be a reason documented as to why parenteral therapy was not given to these patients. So again, the recurrent theme for all this is how well the medical record is documented. The better documentation we have, the safer the patients are going to be, number 1. Number 2, the better chance of patients not falling out on these measures. The population involved here, those patients with an acute VTE, it could be principal or or secondary diagnosis, and these patients these ICD-9 codes are found in tables 703 and 704. And just as an aside, new medication recently came out, was approved by the FDA for the treatment of DVT and PE in Zolredo, and patients who are on this medication are excluded from this measure. So these are the medications that CMS and the Joint Commission will allow to be used as parenteral medications. So Cova, Angiomax, Refludan, Fragment, Lobinox, Inohep. These are all medications that are approved parenteral anticoagulations, in addition to the unfractionated heparin that we've been using for years, and the Rixtra as well. So these are just some of the medications that the agencies are allowing to be used for overlap therapy. This measure is specific to warfarin. So this is the only medication that it's included in this measure. So the patient is not put on oral warfarin; they're not going to be included. So then the overlap therapy is oral warfarin or Coumadin with the parenteral anticoagulation use. So, and here's your rationale. And the rationale is that all patients who have a DVT or PE, we know that parenteral therapy is first line. It works very quickly. However, most patients will go home with an oral medication. When they go home with Coumadin, at times you can see that the INR may be falsely elevated because the coagulation factors tend to linger a little bit. So the CMS and Joint Commission and all the evidence has demonstrated that the overlap needs to be for at least 5 days. And we all know that Coumadin and warfarin is pretty slow to act. I think we touched on this a few seconds ago during the last slide, but patients are still at risk in the early stages of treatment for DVTs. So it's recommended that overlap therapy occur for 5 days to make sure all the Coumadin or warfarin is acting the way it should, and people become therapeutic with their INRs. So now, best practice here, and we touched on this a few times now, is 5 days for overlap therapy as well as an INR greater than or equal to 2. If the patients do not have an INR greater than or equal to 2, the parenteral therapy needs to be continued. And this is all, again, evidence-based, based off of clinical evidence, pharmacologic evidence, pathophysiologic evidence. It's all out there, and we've all seen these countless studies that have shown how Coumadin works and how the heparins work, et cetera. So again, 5 days of therapy is highly recommended for overlap. We're going to go through the numerator here, and we've talked a lot about this in the last couple of slides, but the numerator are those patients who receive overlap therapy. So they need to have an INR greater than 2 prior to discontinuation. If the INR is less than 2 and discharged, they need to be sent home on overlap therapy. There needs to be documentation if we're going to discontinue the therapy. And if there's not going to be overlap therapy, there needs to be a specific reason as to why the medications were not overlapped. The denominator are those patients who have a VTE who receive Coumadin, and that's really it. Those patients can have a principal or a secondary diagnosis of a DVT/PE. The denominator exclusions are very similar, and comfort measures only need to be documented, those in clinical trials. A couple new ones here: patients discharged for hospice care, patients who have expired, people who leave AMA are not included. Patients who are discharged from another hospital are not included as well. And again, those who don't have a VTE and don't have Coumadin obviously are not going to be included in the denominator here. And then CMS and Joint Commission are pretty specific about which tests can be used, as well as where the clot is located. But acceptable tests, and we've all know about these: venography, CT scan, angiography, MRI, MRV, nuclear medicine studies, and this has to be a high probability test, as well as compression ultrasound or duplex ultrasound to diagnose these. And what's interesting here is that, again, you can take the information from a radiology report. It can come from a physician documentation. This documentation can be from records from an outside source. It doesn't necessarily need to be documented by a physician. It can come from a nurse, but it cannot come from billing information. And then we're very specific again about where this location of the clot is located. It could be in the lungs, and then it could be in the lower extremity veins, but the lower extremity veins are isolated to the IVC, the iliac veins, the femoral veins, and the popliteal veins. And we'll see which veins are excluded. Veins below the knee, an upper extremity vein is excluded. Those who have blood clots, or I guess a dorsal venous thrombosis in their brain, hepatic portal splenic, those veins that develop clots, those patients are excluded. The renal vein, ovarian vein, clots, patients with those clots are excluded, and then patients with chronic VTE are not included in this measure as well. We've talked a little bit about overlap in the past, but some reasons why overlap is not used and then documented is that there's a surgical procedure. Patients have had bleeding complications. or the patient refuses. But again, this all needs to be documented why overlap therapy was not used. And the sources for this documentation can come from physicians, nurses, as well as the medication administration records. Jimmy Stewart, pretty famous actor, he also died of a PE. All right, halfway there. VTE number 4, in the exact terminology here are VTE patients receiving unfractionated heparin with dosing and platelet counts monitored by a protocol or by a nomogram. And the measure assesses the number of patients diagnosed with a confirmed VTE who received IV heparin and had their IV heparin doses and platelet counts monitored properly. So that's the measure, that's the description, again, right from the specifications manual. And the rationale is that we all know that heparin can cause problems, bleeding problems, thromboembolic problems, and nomograms have been shown that when used, people will be able to receive the proper PTT level, typically within a 24 to 48-hour period if these nomograms are used. From an adverse drug event standpoint, heparin-induced thrombocytopenia is a problem that we've all seen. Platelet counts tend to fall somewhere between 5 and 10 days after start of therapy. So if the platelets are not monitored properly, they're at risk for having some complications. So it's recommended that those patients who receive unfractionated heparin have their platelet counts monitored as well, in all patients. So simple CBC will be able to pick this up. Now, your numerator are those patients who have IV unfractionated heparin dosing and platelet counts monitored according to defined parameters and protocols. And we're not going to exclude anybody from this population. The denominator, those patients with confirmed VTE receiving unfractionated IV heparin. And again, these could be a principal or other diagnosis or secondary diagnosis code or ICD-9 codes that are found in 703 and 704. And the laundry list of excluded populations is pretty long. And we've talked about these before. If you go down to the second to the last one, patients who do not have unfractionated heparin are not included in the denominator here. When you're talking about unfractionated heparin, again, that's the only medication that's included in this measure. It needs to be documented that it was administered. It could be in the medication administration record, nursing notes, emergency department notes, progress notes, and believe it or not, even ambulance records could be used. I'm assuming ambulance records probably pertain to patients who may come from nursing homes, but nonetheless, an ambulance record can document the use of unfractionated heparin therapy. Heavy D, he was a rapper that died in 2011. He was on a plane coming back from Wales, and they believe that he developed a DVT and a PE shortly after his return to Beverly Hills. So another person who died from a DVT/PE. Okay, VTE number 5. Those patients with warfarin therapy who are given the proper discharge instructions. And we're going to go through these discharge instructions at length. The description here is the measure assesses the number of patients diagnosed with confirmed VTE that are discharged to home care, court, law enforcement, or home on hospice care who go home on Coumadin or warfarin. And the discharge instructions are very specific. They need to address all 4 of these following criteria. Compliance issues, dietary advice, follow-up monitoring, and information about adverse drug events secondary to Coumadin, as well as interactions that Coumadin may have with other medicines. And the rationale here is that education is really important, and education has been proven to be effective in decreasing possible complications from medication therapy. We all know that warfarin, when supertherapeutic, can cause problems, and when it's subtherapeutic, can cause problems. So the better that the patients are educated, and the higher their compliance with their medication use, and the more they understand the potential problems with taking oral Coumadin or warfarin, theoretically, the better off the patient is going to be. There are standard practice guidelines that are out there, and it's been proven to be effective. So here's your numerator, and it's the patients with documentation that they or their caregivers were given written discharge instructions or other educational material about warfarin that address, again, all four. So compliance, diet, follow-up monitoring, and then potential adverse drug reactions or interactions. And we're not going to exclude anybody from this population. And your denominator are those patients with confirmed VTE who go home on Coumadin. And these are then patients with the principal or secondary diagnosis of VTE. And they can go home, they can go to hospice, but when they leave the hospital on warfarin, they're going to be included in this population. The exclusions are pretty similar to what we've seen before. Less than 18, more than 120 days in the hospital, patients in clinical trials. If they're not given warfarin at discharge, they're not going to be included in this measure. The documentation must be written. You cannot just talk to patients about it. It's got to be documented in medical records that written instructions were given. And the abstractors will assume a copy was given to the patient if there's records that state the patient's name, the medical record number, as well as you need a signature from the nurse as well as the patient stating that the instructions were received. If the patients refuse to take their instructions home with them, it just needs to be documented in the medical records. So again, the theme here, again, is documentation is vital to making sure that the patient is taken care of properly. And number two, make sure that they're included or excluded properly from these measures. You talk about compliance issues, both of the following need to be put in the instructions. You need to tell the patient they need to take warfarin as instructed, and they need to be told that monitoring warfarin intake with scheduled INR checks is very important as well. So these two need to be put in your compliance information for the patients. When you talk about dietary advice, again, there's two statements that need to be here. Patients don't need to avoid foods with vitamin K, but need to eat a consistent amount of vitamin K. And if a patient decides that they're going to change their diet, you need to discuss this with a pharmacist or with their physician or health professional before they do this. When you talk about follow-up monitoring in the discharge instructions, there's got to be a plan put in place so that patients can go to an office, a Coumadin clinic, a home health care provider can come out to the house and take a blood sample. You also need to have a schedule for the patient as to when the next INR is being checked. And then when you talk about adverse drug events or interactions, it needs to be told, the patients need to be told specifically that diets and medications can affect the INR. Patients need to be told, again, that they should not stop or start medications in general without the advice of a physician or pharmacist. And there needs to be statements stating that warfarin or Coumadin increases the risk of bleeding. Formats for use, a copy of instructions need to be given. You need to have documentation the patient had a copy to take home. The patient needs to sign for it, as well as the nurse or physician needs to sign that the patient received their information. There needs to be a copy in the medical records that the hospital has on file. And again, there needs to be a statement that written instructions were given. It can be signed by a nurse. You must list the individual areas of instruction, and then just beware that if you're using a form with check boxes, if the box is not checked, it infers that it was never done. So again, beware of these check boxes that are being used in these instructions. Serena Williams, she's still alive, but she had a PE, I think it was last year. So she's a very famous tennis player, in great shape, and she developed DVT/PE. So it happens to people that they're not old or not hospitalized as well. All right, last one, VTE number 6. And this is a little bit different than what we've talked about in the past, where you want the numerator and denominator to be really close to each other, if not the same exact number. Here you want the number to be 0, and you'll understand this as I go through, but this is an adverse outcome measure. The description of this measure exactly is: measure assesses the number of patients diagnosed with confirmed VTE during hospitalization who did not receive VTE prophylaxis between hospital admission and the day before the test was ordered. And the rationale is that there's a really high incidence of DVTs and PEs in patients who are hospitalized. And what happens is when these patients develop these complications, the length of stay increases in the hospital, increases the cost of taking care of these patients as well. A article published in 2003 told us that VTEs are the second most common medical complication of postoperative patients, second most common cause of excessive length of stay, and the third most common cause of excess mortality and excess charges, in our patients. So it's a pretty, again, you'll see how important taking care of these patients are properly. A little bit more rationale for you. Preventable VTE is defined as objectively diagnosed DVT or PE that occurred in a setting in which thromboprophylaxis was indicated, but either was administered inadequately or not administered at all. And we all know, as we've been talking, DVT PEs is the most common preventable cause of death among hospitalized patients. The numerator are those patients who received no VT prophylaxis prior to the VT diagnostic test order date. And again, we're not going to exclude anybody from these measures. And your denominator are those who developed confirmed VTE during hospitalization. And these patients have a secondary diagnosis code of VTE. So if you go back, and you want to look at it this way, you want the number you don't want a lot of patients who did not receive prophylaxis. So let's say your number here is 10, and patients who developed VTEs is 10. You're going to have a rate of 100%, which is not the direction you want to go. You want to go in the direction of 0 in this case. Patients that are excluded are the patients less than 18, again, in the hospital more than 120 days, clinical trials, confirmed measures only. If the patient has a VTE present at admission, they are not included in this measure set. Here are some commonly overlooked patients that may not get VTE prophylaxis. Those are at moderate risk, and it's felt that they don't need it. People coming from the emergency department sometimes don't have their VTE prophylaxis ordered, and then patients who are conservatively managed, they may not get VTE prophylaxis either. And this, again, all these patients need to have it. And as I talked about before, we're aiming to 0 here. VT6 captures adverse outcomes, and again, the goal is 0% on this measure. The numerator, those patients who went on to develop VTE because of no or insufficient prophylaxis. However, in reality, the measure captures those patients who do not get prophylaxis in the numerator. And then patients who develop a VTE despite prophylaxis, they do not count against the hospital. So if they had the right prophylaxis, they're going to be still put in the denominator, and they're not going to count adversely against the hospital. When I'm talking about present on admission, it's got to be documented that the physician, nurse practitioner, the PA needs to document in the medical records that the patient had a VTE on admission, or you need to have the diagnostic test ordered on the admit date. And then you can't go back retrospectively as well on your records. So some documentation issues to keep in the back of your mind. From a documentation standpoint, again, this can come from the physician, the pharmacist, the nurse practitioner, the PA. If pharmacoprophylaxis is not given, again, you need to document both mechanical and pharmacological methods. Patient refuses, needs to be documented again. It could be documented by all the caregivers in the hospital. And when you're documenting that prophylaxis was not given, you must clearly link the reason prophylaxis was not used for both types, so pharmacologic and mechanical, and need to address both extremities. I know it sounds kind of strange, however, this is one of the requirements as well. When you're documenting these reasons why you're not giving prophylaxis, a history of bleeding is not adequate. Informed consent, saying the risk of bleeding is there, is not a reason as well. You can't just state patient is low risk or VT prophylaxis is not needed. You need documentation, you need a reason, you need to state exactly what is going through your mind when you document this, so the patients will either be excluded properly, or if they're included, there are reasons as to why things were done. So the better you document, the better off we're going to be. John Lord, he famous songwriter. I believe he founded the group Deep Purple. However, he also died last year of a DVT/PE. So we're going to conclude in a couple moments. Just remember that when you're documenting in the medical records, it's thorough, it's complete. Your rationale and your reasoning gets put down either when it's being dictated or being written. But it's really important that everything is documented properly, or else the provider or the hospital is at risk for patients falling out of these measures. When you're doing your discharge instructions, the discharge instructions need to match either the short stay summary or the discharge summary that's being dictated. If they don't match, you're at risk as well for having your patients fall out of these measures. So the discharge summary and discharge instructions need to exactly match themselves, or else there's going to be run into some problems. So here's some CME information for you. This is going to be available until the end of February. There's a link on here as well, and then Mary Lee Evers needs to have your post-test, so you can submit it to her. And if anybody wants to get a hold of me, again, I'm Howard Chaps, and there is my contact information. And thank you all very much for listening, and have a great day.